Welcome back to another Decode Healthcare Explainer. I'm your host, Harshal, and today we're putting on our coding trainer hats to really master those specialized modifiers for diabetes management. Look, if you're submitting claims for diabetic patients, you already know the drill. Precision isn't just important, it's literally everything. We're talking razor-thin margins and, let's be honest, pretty frustrating payer portals. You miss a single modifier? Boom. Instant claim denial. That means delayed payments, massive headaches, and so much wasted time. Well, today, we're going to fix that. We're diving deep into the specific modifiers that routinely trip up even the absolute best billing pros out there. All right, here's our roadmap for today. We're going to systematically break down the compliance rules across 4 major areas. We've got clinical and procedural modifiers, DME and nutrition services, telehealth modifiers, and finally, injectable drug modifiers. Let's jump right in. So, kicking things off with our first section, clinical and procedural modifiers. We're going to hone in on modifiers 25 and 91 here. Okay, the big thing here is same-day services. Let's say you're managing a patient's peripheral neuropathy, right? And on the exact same day, you also interpret their continuous glucose monitoring data, CPT 95251. You absolutely have to append modifier 25 to the EMM code. Why? Because if you don't, the payer system will just assume the EMM was a standard part of the CGM procedure, and they're going to auto-deny it. No way around it. Think of modifier 25 as your giant neon sign telling the payer, hey, we did the procedure, but we also did completely separate significant evaluation work. Handling multiple manifestations at once is super common in complex diabetes care, so nailing this is crucial to actually getting paid for the time you spent. Let's test your knowledge with a scenario I'm sure you see all the time. A patient comes in with hypoglycemia. The provider does a glucose test and confirms the low blood sugar. The patient takes their glucose supplements, and now the provider needs to run that exact same test again 30 minutes later just to make sure those levels are safely back to normal. So, how do we code that without the payer thinking we just accidentally double-billed them for the exact same test? Yep, this is exactly where modifier 91 shines. You report the first test is CPT code, and then you report that exact same code a second time, but you tack on modifier 91. This modifier exists for this exact reason, to say, yes, this repeat clinical diagnostic lab test was medically necessary on the same day. It proves to the insurance company that it wasn't a glitch, but a vital follow-up to check how the patient responded to treatment. Using 91 correctly completely protects your revenue for that medically justified repeat testing. Moving right along to our next section, durable medical equipment and nutrition services. Now, you know as well as I do, this area is watched like a hawk by Medicare and private payers alike. Let's talk glucose monitors and supplies, like your test strips and lancets. You're going to use modifier KX to justify higher volume limits for patients who are treated with insulin. On the flip side, use KS for those standard lower limits when the patient is not treated with insulin. These HCPCS modifiers are basically telling the payer exactly why you're dispensing that specific volume. Because insulin-dependent patients have to check their blood sugar way more often, that KX modifier acts as your promise to the payer that the patient actually meets the strict policy requirements for that higher volume. And if they manage their diabetes with just diet or oral meds, KS clearly designates that standard lower limit. Simple as that. Now pay close attention to this because it's an absolute golden rule for coding compliance. You must never, ever put both KX and KS on the same claim line. I know it sounds like common sense. A patient obviously can't be both insulin-treated and non-insulin treated for a single supply, but you'd be surprised. This simple contradiction is a massive trigger for automated claim rejections. Always double-check to make sure only one of these modifiers is representing the patient's treatment status on that specific line item. Sticking with this category, let's look at nutrition and diabetes self-management training. You want to use modifier AE. Think of this as your credential flag. It proves to the payer that a registered dietitian or nutrition professional actually provided the therapy. Then we have modifier TS. This is your timeline tracker. If you're doing a follow-up, say a prediabetes evaluation using a screening code like 82947, appending TS clarifies to the payer this isn't an initial encounter. This is ongoing preventative care tracking. Okay, on to Section 3, telehealth modifiers. With a massive rise in remote care, let's lock down the specific modifiers for remote diabetes coaching and CGM instruction. When you're interpreting data or doing diabetes coaching remotely, the payer really dictates your modifier choice. You're mostly going to use 95. That's for your standard, synchronous, real-time live video visits, the typical virtual calls we do every day.
Now, some older systems or specific payers might still ask for GT for interactive audio and video, but here's the one you really want to circle, GQ. This is for asynchronous systems, meaning the data is stored and forwarded later, not reviewed live. It is heavily utilized by various state Medicaid programs, so definitely check your local payer rules when you're dealing with asynchronous data review.
And that brings us to our final section, injectable drug modifiers. Plus, we'll quickly touch on some vital quality and anesthesia codes you absolutely can't afford to ignore.
So, for those expensive single-dose diabetes therapies administered in the office, you are dealing with a strict either-or scenario. You either append JW to report the exact amount of a single-dose vial that was discarded, or you use JZ if you administered the whole volume with zero waste. Payers want to know exactly where every single drop of that expensive vial went. If a vial has 10 units, but the dose was only 8, you've got to use JW on a separate line to explicitly report those 2 discarded units. But if they got the full 10, use JZ to confirm zero waste occurred. Oh, and a couple of quick add-ons while we're talking highly specific tracking. If you manage the Medicare Diabetes Prevention Program, remember you need modifier VM for virtual makeup sessions. And for your Category 2 quality reporting exclusions, keep your 1P for medical reasons, 2P for patient reasons, and 3P for system reasons top of mind.
Before we wrap up, do a quick mental check of your recent claims. Are you absolutely certain you aren't risking denials? Are you using Modifier 25 when managing peripheral neuropathy alongside CGM interpretation? Are those single-dose injectables mapped correctly with JW or JZ? And one last critical thing. If your diabetic patients go in for surgery, are your anesthesia physical status modifiers totally accurate? They range from P1 to P6, right? But specifically for diabetes, remember, P2 is for controlled diabetes, P3 is poorly controlled diabetes, and P4 is uncontrolled diabetes with a severe systemic disease, like end-stage renal disease. Mixing those up directly impacts your surgical reimbursement. Mastering all of these modifiers isn't just a compliance exercise. It's how you ensure your practice actually gets paid for the incredibly complex care you provide.
Well, you've now got the tools to protect your revenue and stay compliant. Thank you for joining this explainer to elevate your coding accuracy. Like, share, and subscribe to Decode Healthcare with Harshal.